Good morning, and first of all, let me thank Dr. Somshila and the scientific committee for having me here in this session. And so I will be talking about innovations in surgical management of uveitis and how surgery can help us and how it is evolving over a period of time in our managing of these cases. Now, essentially, if you look at vitreoretinal surgery and how it evolved, this was the first initial device which was used by Dr. Macamber. But from that device till now, when we have got 27 gauge vitrectomy systems, which just essentially make an entry of 0.4 millimeter inside the eye. You have got vitrectomy systems with cut rates going up to as high as 20,000 cuts per minute. So what we are now seeing are less invasive, shorter operating time and a faster recovery for many of our patients, and that has broadened the horizons of VR surgery in a lot of these cases. So how can vitrectomy help us? Now, vitrectomy has always been there. It's not something which is new, but what is new is the improvement in the machines and the less invasiveness of the procedure. So now there have been multiple studies which have shown that vitrectomy can be used not only as a diagnostic tool but also for removal of vitreous opacities and removal of inflammatory mediators, which is subsequently leading to a reduction in the need for systemic immunosuppression as well as in the reduction for the long-term usage of steroids, apart from helping us in taking care of the complications that happen in some of these uveitic entities, including macular edema, epiretinal membranes, and the detachments and hemorrhages that can sometimes happen in these eyes. So the way vitrectomy has improved, it's not, to be honest, an innovation, but essentially a significant improvement from the systems that we have earlier. So this study, which was done initially, showed that it helped in establishing a diagnosis, in reducing the need for drug therapy and reducing macular edema apart from management of hypotony. Also, it now allows us to take samples which can be sent for cytology and for cytokine analysis so that we can arrive at a diagnosis which becomes more important in cases of lymphoma and where we are suspecting other etiologies and where there are diagnostic dilemmas. So surgery also comes to our rescue when we need to arrive at some of the diagnoses in these dilemmas. But now let me show you one more innovation actually, which is changing the way we deal with some of our uveitic cases. So this was one patient which came with this dense complicated cataract, history of decreased vision in the eye since 5 years. Vision was PL plus and projection of rays in all 4 quadrants, low IOP, hypotony, and UBM and B scan did not show us anything significant. So this was case number 1. And this is case number 2, 19-year-old female with decreased vision again since 4 years. Again PL plus PR plus 4, again an IOP which is low, hypotony, and again a UBM which was done did not show any extensive ciliary body membranes, nor did the ultrasound show us anything significant. So now how do you go around tackling these cases where there is absolutely no visualization of the posterior segment, where you do not know what is happening behind? And that is where this innovation has started becoming very important for us, which is endoscopy. Now the first endoscope was developed in 1934, but the modern endoscopes that we use have been there since 2011, though they have now in the last 4 or 5 years become much more popular and have become much more a part of our treatment and armamentarium. So this is the endoscopy system where you have got a fiber optic cable which has got a built-in camera which is there in the microprobe with which you can visualize what you are seeing inside the eye. So this has also got an inbuilt laser, though we do not use the laser that much commonly, but the camera does allow us a significant visualization of what's happening inside the eye, and it helps us in assessing difficult to access sites including sulcus, sclerotomy sites, ciliary bodies, pars placata. It also becomes useful in these cases of refractory glaucomas where you can use it for endoscopic endocytophotocoagulation. So this is how basically the system is. You're not looking inside the microscope, but you're looking at a TV screen, and let me show you how it helps us. So these were some of our cases. One of them, or 2 of them are basically post-corneal interventions. But the reason I wanted you to show this image was essentially to realize how it helps us. So this was a case with an extensive corneal opacity. The B scan seemed to be normal. But when we went inside, what we found was an absolute complete optic atrophy with disc pale and with sclerosed vessels. So this was an eye where subsequently we ended up doing no intervention. Again, an eye with keratoprosthesis with a B scan showing a detached retina, but it just shows the detached retina. It does not show you the configuration of what is happening to the retina. And an endoscope allows us to visualize the fact that the entire retina was necrotic. The same holds true for this case where the B scan will show you a detachment, but when you go inside you realize this is an inoperable case. So these are eyes where it is helping us in prognostication, in understanding what is happening inside the eye. probably these are cases where you do need to now give up and realize that there is no further intervention which is going to help this eye. But then on the other hand, you have got eyes like this where you have again got no visualization. But when you do a diagnostic endoscopy, what you realize is that you have got a completely attached retina with a healthy disc. So these are eyes which are amenable to subsequent interventions. This is an eye where subsequently a graft was done and this patient ended up actually having a visual acuity of 20/50 subsequently. So in eyes like this, in uveitic eyes, there are some of these cases where we have now started doing a diagnostic endoscopy initially to prognosticate before we decide to go ahead with any further intervention. So this is the other indication where now endoscopy has started becoming more and more important in our uveitic cases, which is to look at what's happening to the ciliary body. So in eyes which have got a persisting hypotony, where you have got the ciliary body membranes, now what we can also do is that we can go ahead and remove some of these ciliary body membranes, assess and what is happening to the ciliary body and visualize these membranes and go and remove them either with the help of a cutter or with the help of a scissor. So this was another patient of ours with a hypotony maculopathy. You look at the B scan, again all of these choroidal folds over here, and a UBM does show us a few membranes, and what we did was in this case was that we went ahead, removed all of these membranes, and we essentially plicated and cut and tried to remove as much of those membranes with the help of our forceps. Ended up putting 5000 oil inside the eye, but the IOP has started improving and the patient is likely to do well in future. So now basically how does changes in VR surgery or in surgery help us? They are allowing us an early as less traumatic interventions. They are also allowing us with the help of an endoscopy to visualize things and features which were earlier not amenable to visualization with conventional viewing systems, and is also allowing us to take care of these peripheral membranes which can cause havoc in a lot of these uveitic eyes. Thank you so much. I would also just take 10 fleeting seconds to invite you to these two upcoming meetings. One, Dr. Sudarshan had already spoken about the UCCon meeting in Jammu in October, and the other meeting which is happening in LV Prasad Institute in May, which will have different sections and workshops on all of these things that I spoke about, including use of fibrin glue and endoscopy and laser workshops and different instruction courses. So please join us in both of these meetings. Thank you so much.
Thank you, Dr. Mudit, for the excellent illustrative video talk with the surgical intervention. So yes, it's these cases is one prognosticate when you operate on this, when the presence of the media hairs. How do you follow up these patients post vitrectomy when there is no visualization?
So then so there are two ways. Essentially that's one of the biggest problems in these cases is how do you go around following them up. But once you have done a vitrectomy, you know what's happening inside the eye. Subsequently a B scan can still be used to follow these eyes up, but initially not. And for uveitic eyes, once you have done a lensectomy, remove those membranes, the visualization improves. Their endoscopy works more for helping us in taking care of those peripheral hypotonic membranes.
Thank you so much.
Thank you.